Afternoon, good evening, good morning. My name is Summer Farman. I am a stage 4 ALK-positive patient diagnosed in June of 2020. Tonight, we are missing our ALKtALK founder and host, Mark Rosenzweig. He is feeling a little under the weather and could not be with us. But for those of you that don't know, Mark was diagnosed 10 years ago. And about 3.5 years ago, had this brainstorm during the COVID outbreak. Just as I was being diagnosed, he decided to take the Zoom platform and help make our ALK-positive community a little smarter and a little bit smaller. With the help of our dear friend, the late Gina Hollenbeck, Mark brought experts to the ALK community to empower us by offering us all information and inspiration. It has been my pleasure to assist Mark with his brainchild for the past 3 years. Tonight, we have the fabulous Dr., or as they may call him, down under, Professor Ben Solomon. He's joining us before his Monday morning clinic. Okay, how crazy is that? We are so blessed and so fortunate. Straight out of Melbourne, Australia. So he is bringing us some exciting information for our early stage ALK-positive patients, but is also here to take your questions on all things ALK-positive. Not personal, by the way. Please do not submit results of your CT scans into the chat, but in general, your ALK questions. Helping me to moderate this talk is patient and super advocate, fellow ALK-positive board member, Yvonne Diaz. And also helping me to control the Zoom room, behave y'all out there, is Dana Corrido. She is also the coordinator for ALKtALK and the Healing Arts. So thank you all for joining us. Also helping is Katie Delaney of ALK-positive Inc. So thank you to this team. I am so blessed to have you all here. Let's start out with a couple polling questions and then get right to it. But again, just to be sure, we can get a little feel for our audience. Also, we do want to be sure that we get Dr. Solomon out on time, and we're not the reason to slow up his clinic day. So if all of you could hang around to the end after we thank him and say goodbye, I do have another polling question that I would like to launch for a future ALK talk, and also a little project that I need your help on. So hang around for the hour if you are able. Okay, here we go. Let's see here. So polling questions. Here is the first one. Diagnosed. When were you diagnosed? So go ahead, take a look. I'll give you a couple seconds. And then I will read the results. All right, come on, everybody. 75% participated. Anybody else? All right, we're good. I'm going to end the poll and share the results. You can see here the majority 1 to 2 years, a tie for under a year, and 3 to 4 years coming in at 19%, 8% 4 to 5 years, 3 to 4 years, 7%, 6 to 7 years, 7%, and 8 or longer, 7%. So thank you all for joining us and answering that. We have a wide variety. Okay. Let's see. And stage of cancer. What stage is your or your loved one's ALK-positive cancer? And I didn't include in here A, B, whichever, just take your best pick on your number. Okay, good job. We had 85% participation. Thanks, everybody. I like it. Okay. And as expected, 72% of us are stage 4, but we have stage 2 and stage 3. Awesome. Thank you. Thank you. Good job, everybody. And let me just check. I feel like I had one more. Okay, treatment. Let's do that real quick. Treatment. What type of treatment are you receiving? Make sure you scroll down because it does say no current treatment at the very bottom if that happens to be the case. All right, good job. Way to participate. Okay, I'll give you another second. 82% we're at. I'm so proud. 85. Okay, and the poll. 73% on alectinib. Okay, brigatinib is at 6%, and that's without Yvonne and I. We are proud brigatinibbers here. Lorlatinib at 11%. See, Mark does this so effortlessly and categorizes them. I'm a slow learner, sorry. Chemo and TKI, 2%, just chemo, 2% clinical trial too. Thank you to those of you paving the way for us, and no treatment, 6%. Here, I don't know if I show those. You can take a look. All right, Yvonne, if you want to take it away.
Yeah, I'm just going to say really hello. It's such a pleasure to be here with you. As Summer said, I'm an ALK-positive lung cancer patient as well, diagnosed in August 2021. I had the pleasure of meeting Dr. Solomon, the investigator for the Alina trial, just a few months ago at the ESMO Congress in Madrid. He presented these latest results for the first time and had the whole audience transfixed by the successful results. So it's really exciting to have him with us here today to break this down for our patient and caregiver community. So I'm really glad to have him here, and really just hand it over. And after Dr. Solomon finishes, we'll have some Q&A and you can ask your own. So thank you so much. Over to you, Dr. Solomon.
Thanks, thanks so much, Yvonne and Summer, for the invitation and the very nice introduction, and good afternoon and good evening, I think, to most of you, and maybe good morning to a few of you who might be from my part of the world. I'll just share my screen, and maybe Summer and Yvonne, you could just confirm that people can see that.
Looking good.
That's good. Okay, so I think as Yvonne was saying, I'll be talking about moving treatment with ALK inhibitors into the early stage setting. And this is a little bit different from, I guess, the area that all of you are most familiar with, treatment for more advanced disease. But I think it is important to be aware of what's happening in the field, and hopefully see the direction that things are moving at. So I'll be talking to you about results of a phase 3 clinical trial called the Alina trial, which looked at treatment with alectinib after surgery in patients who've had what we call early stage ALK-positive lung cancer. And I'll talk through that in a bit more detail. So firstly, this I guess all of you are familiar with. ALK gene rearrangements are found in about 5% of patients with advanced non-small cell lung cancer. And although they tend to be more frequently found in younger patients who've had not smoked or had a relatively light history of smoking, we know that they can be found in other tumors, and we really recommend and emphasize the importance of testing all newly diagnosed lung cancers for ALK rearrangements. And the reason that this is important is because these tumors are very sensitive to treatment with ALK inhibitors, and more sensitive to treatment with ALK inhibitors than chemotherapy. And this has really changed the landscape for advanced lung cancer. But we also know that patients with early stage lung cancer can have tumors with ALK gene rearrangements. We don't have a good feel for the exact percentage, but it's probably a similar proportion of early stage tumors that are positive for ALK rearrangements. And what do we know about early stage tumors? Well, we know that although they may be operable, and patients can undergo surgery with the aim of curing the cancer, recurrence rates are high, and survival is really not that great. And whilst we've seen some improvements with immunotherapy given either before surgery, we call that neoadjuvant treatment, or after surgery, we call that adjuvant treatment, these advances don't really seem to apply for ALK-rearranged tumors. And we also know that in the advanced setting where we see that treatment with immunotherapy given on its own has very little activity in advanced ALK-positive lung cancers. So really all that we've been left with after surgery is chemotherapy. And we know that the results with chemotherapy are modest, I think would be a fair description. At 5 years, patients who have chemotherapy after surgery have about a 5% improved survival. That's good, but I think that's something that, well, good is in the eye of the beholder, but I feel that this is something that we really need to try to improve. So there have been a whole bunch of studies that have started, and that many of which are ongoing, looking at treatment with ALK inhibitors, both in the adjuvant setting that's given after surgery, but also in the neoadjuvant setting where it's given before surgery. One of these trials is a trial that has been conducted in the US, and it's still going. It's a trial called the Alchemist trial, and it's a trial that started a few years ago and still hasn't been completed. And it's a trial where patients who had surgery for resectable, so early stage tumors that were diagnosed and found to be suitable for surgery, had their surgery. They could have had their chemotherapy as well. And then they were randomized to treatment with crizotinib or observation. And this trial has been quite slow to accrue and still hasn't completed accrual. And this is a challenge. And part of the reason for that is not that many tumors were being tested for ALK rearrangement. So many patients who might have been eligible for this trial may not have even been identified as such. The trial size, the investigators felt that they had to reduce the trial size from 378 to 168 patients, but it's still ongoing. And as we know, the field has moved on with the development of newer ALK inhibitors. And I think many of you will be familiar with this compound, alectinib, judging from the survey that Summer did. So we know that we know from at least 3 trials that alectinib has better results in patients with advanced disease than crizotinib, both in terms of controlling, disease outside the brain, but also importantly in the brain. And we're very familiar with the toxicity profile of alectinib. So it made a lot of sense to see if patients with advanced disease could benefit from alectinib. Could patients with early stage disease also benefit from alectinib? So that formed the basis of this trial called Alina. And if we look in a bit more detail at the design of the trial, so the trial was a global trial, so it was conducted around the world. There were 26 countries around the world that were involved in the trial, 113 centers. And to be eligible for the study, a patient had to have what's called a stage 1B to 3A lung cancer. We don't need to worry too much about the details about that, but these were tumors that were confined to the lung or involved just some lymph nodes that were still amenable to surgery. And if patients had complete resections of their tumors and the tumors tested positive for ALK rearrangements by local approved tests, they were eligible for treatment on the study. And in this study, patients were randomized 1-to-1 to receive either standard treatment, which was 4 cycles of chemotherapy, or to treatment with alectinib. And the alectinib was given at the standard dose of alectinib, which is 600 milligrams twice daily, that's 8 tablets a day, for 2 years. And then they were followed up with scans, including, importantly, MRI scans to look to see what happens in terms of control of the disease in the brain. And the primary endpoint of the study was something that we call disease-free survival. So disease-free survival means the time that people are alive without evidence of disease. So if a tumor comes back, it's counted as a disease-free survival endpoint. There were other important endpoints, including control in the brain, overall survival, and safety. So about 130 patients were randomized to each arm. We often look, when we're looking at phase 3 trials, it's important to look at what we call patient characteristics to make sure that the study is a fair comparison between arms, and also understand the group of patients that are going on the study. So they were pretty similar across both arms, although there was slightly more women in the alectinib arm. There was slightly more patients who had never smoked in the alectinib arm. What was also interesting was about half of patients had what we call N2 disease, which means lymph nodes in the middle of their chest, which is probably a little bit more than we expected. And this might tell us a little bit about the biology of ALK-positive lung cancer in the early stage setting. And we'll find out more about this, about the biology from additional studies that are planned on the samples collected on the Alina study. So this is the key slide in terms of the results of the study, the effect of alectinib in reducing the risk of tumor recurrence or death. And just sort of talking you through the curves. So these curves, I'm sure you've learned a lot about statistical analysis of outcomes in lung cancer, but this is a type of curve called a Kaplan-Meier curve. And what we see in red are outcomes in the chemotherapy arm of the study. And the y-axis is the proportion of patients that are free of disease, and on the y-axis is time. So what you can see with the red curve is over time, unfortunately, we see a steady rate of recurrence of the lung cancer, and at 36 months, 54% of patients are alive without recurrence, which means that 46% of patients have developed recurrence of their lung cancer. And in contrast, in the alectinib arm, you can see that this effect is much reduced, and alectinib is able to prevent recurrence in many patients. And in contrast, at 3 years, nearly 89% of patients are alive and free of disease. So only 11% of patients have developed recurrence, compared to 46% in the chemotherapy arm at 3 years. Another number that you'll hear about when we're talking about curves is something called hazard ratio. So the hazard ratio is 0.24. What that means is that compared to chemotherapy, there is we've got to sort of look at this a little bit sort of in an inverted way in terms of the numbers, but a 76% reduction in the risk of recurrence with alectinib treatment. So really strong effect in reducing the risk of recurrence. Now, does this mean that the patients are cured? We don't know that yet. We need to get more time to look at something called overall survival to fully understand that. But you can imagine, to be cured, you need to be free of cancer. So I think this is an important and really positive result. And we know with a trial called ADAURA, which is a trial in EGFR lung cancer, when we see such a big difference in disease-free survival, that can translate into an improvement in overall survival. So in terms of this study, we don't have overall survival results. I think it's a good thing. Only 6% of patients had died on the study, which means that, and that again, I think it's a good thing that we're going to have to wait a long time to get the overall survival results. We also looked to see whether there were any groups that seemed to benefit differently from other groups. And what we can see is that benefit seems to be observed across the different groups. Age didn't matter, whether you were male or female, whether you're Asian or non-Asian, whether you had smoked or not smoked. And importantly, also, benefit was seen regardless of stage. And if we look at this in a bit more detail, in stage 1B through to 3A patients, there was benefit seen. Stage 1B, relatively small tumors without lymph nodes. And with stage 2 and stage 3A tumors, you can have bigger tumors with lymph nodes involved. We also have good data about what happens in the brain, and we know from what we've learned from studies in advanced ALK-positive lung cancer that that metastasis to the brain is an important problem. And what we've seen in the Alina study is that in compared with chemotherapy, ALKtALK is able to reduce the chance of recurrence in the brain. So in the results that we've got so far, in the chemotherapy arm, 14 patients had recurrence in the brain compared to only 4 in the ALKtALK arm. So the hazard ratio is 0.22. That's a 78% reduction in the risk of CNS recurrence. What about how well the drug was tolerated? So remember, these in this study, ALKtALK is taken for 2 years. So about a quarter of patients needed to have interruptions of dose or dose reduction, but only 5% of patients needed to stop treatment. And if we look at the type of side effects that patients had with ALKtALK compared to chemotherapy, with chemotherapy, we see the typical side effects like nausea and vomiting, trouble with blood counts. With ALKtALK, we also see what we've come to expect in patients with advanced disease, and that's some lab abnormalities like elevation in something called creatinine phosphokinase, and in some of the liver function tests, but also side effects such as constipation, muscle aches, which we also see, but which we can talk about this later, but which are generally manageable. So that's the Alina study. What about other studies that are ongoing? There's a lot of interest in giving treatments before surgery, potentially as well as after surgery. And there are 2 or 3 trials looking at this. One's called the Nautica trial, which is in the US, and the other is an Italian study called ALNEO. And I think it's really too early to talk about the results from these studies, but we hope that they will further improve outcomes for patients with early stage ALK-positive lung cancer. There's also a study in patients who have disease that's too advanced for surgery. Some patients have treatment with radiation together with chemotherapy. We call that chemoradiation. And there's a trial called Horizon 1 looking at ALKtALK after the chemoradiation compared with immunotherapy, which is the current standard treatment. And I think this is another important study. So I guess to summarize, we know that ALK inhibitors, and in particular newer generation ALK inhibitors, have really transformed outcomes for patients with advanced ALK-positive lung cancer. And we now have data that they may benefit patients with early stage ALK-positive lung cancer. And Alina is the first positive study of adjuvant, so given after surgery, ALK inhibitor. And it resulted in both a statistically significant and clinically meaningful improvement in disease-free survival and control in the brain. So we know now that not only is it important to test patients diagnosed with advanced lung cancer for ALK rearrangements, but it's also important to test newly diagnosed early stage lung cancer to work out the best treatment. And there are a bunch of other studies which are ongoing in both early stage and in locally advanced disease. So I think I'll end my presentation there and hand back to you, Yvonne.
Thank you. Thank you so much, Dr. Solomon. Wow, what an incredible set of results. It's so exciting to have that for our ALK community. So thank you so much for taking us through that. For my first question, I wanted to ask you, before we get into what the data means, I was going to ask you about the ties that you normally wear with your presentation. Dr. Solomon, for those who are not aware, he's not wearing his tie today, but he normally somehow magically matches his tie to the data. So I was really wondering what was going to be in store for us today, and I was a little surprised that you don't have your tie on.
Thanks, Yvonne. No, so this is I last year I had two, so I very rarely wear ties. I don't wear a tie at work and very rarely at meetings, but last year I had the privilege of actually discussing the ADAURA study at ASCO, which is a big meeting, thousands of people in the plenary room, and so I thought I'd better wear a tie, and I thought I'd match the tie to the ASCO template, which was a green, blue, and white outfit. But then when it came to ESMO, the template I thought was rather dull. It was a gray and blue template. So I said, we can't do this. We need to change the color of the slide. So we went with the red and the blue, and I got a bright red and blue tie. So I'm not a very fashionable person, and but I did put a bit of effort into tie choice for the presentation.
Well, you've come in perfectly attired for our group tonight, so nice to see you, just a bit open and more relaxed for us. So, maybe to start, the first question really could be, what does the Alina study mean to ALK in general? Maybe you can just give an overall picture on what you think this means for us.
Well, I think for so what I guess I've come to learn, and you guys know this, I've learned from people like all of you that lung cancer is a community. It's yes, it's a bunch of individuals, but it's a bigger group, and I think probably the biggest thing from the Alina trial and the other adjuvant trials, including in EGFR lung cancer, is that what we've learned from the advanced setting, what we've learned from people like all of you participating in trials, having treatments, is how these drugs work in the advanced setting, how we can improve on drugs. And this trial is moving that knowledge to the early stage setting to benefit a whole different group of patients. Actually, not that different. They're not. It's really the only difference is the time that they were diagnosed. And what we hope now is, as as we get better at diagnosing lung cancer at early stages, there'll be more and more of people diagnosed at the stage where it's potentially resectable. And so I think that's probably the biggest thing, that we sort of extend the benefit to bigger groups of patients.
Yeah, no, I think that's really true. And I guess that really reminds me of biomarker testing, right? I mean, we see that often those patients we do meet, or that know they have early stage disease, not all of them have received biomarker testing. Sometimes their local clinician might see, well, we'll just give you this curative treatment. It's not covered by insurance in some countries, or perhaps it's not in the guidelines of a certain country. And we'll just see what happens. So I don't know if there's anything that we should be doing as a lung cancer community to try and change that as well.
Yeah, I think that's changing in the sort of medical community, because as we're seeing approvals for immunotherapy and adjuvant osimertinib, and even for immunotherapy, to use immunotherapy, we need to make sure that the tumors test negative for both EGFR and ALK. So that's sort of getting molecular testing front of mind, which is important. And as hopefully we see approvals and reimbursement, which is another issue around the world, for osimertinib and hopefully alectinib, then I think that will sort of make it absolutely critical to do the testing, and will actually help drive that. But I think you know, we know in the advanced setting that despite the availability of drugs, testing is still not optimal. So there will still be a lot of work to do in the early stage setting as well.
The data really was quite clear that the alectinib arm performed so much better than the chemo arm at 93.6 versus 63.7. And I guess to put it into practicalities, if someone in our community had surgery, then was given chemotherapy and not put on a TKI, should they be speaking to their oncologist about this?
Yeah, that's sort of a tricky one. I think the data are clear, that there's benefit, and I think it is worth a discussion. I guess we don't know. In the Alina trial, the treatment was started within 12 weeks of surgery. And I guess we don't know if that time stretches out to 3 months or 6 months, whether the same benefit would hold. So it's an area of uncertainty. I think I'm seeing a question come up in the chat about chemotherapy as well. We know that alectinib is better than chemotherapy, but we don't know, that the trial didn't address whether there might be additional benefit from both chemotherapy and alectinib. So I think those are areas of uncertainty. And also there's, at least in around the world, there are huge sort of issues of financial toxicity, and the cost of paying for 2 years of alectinib or 3 years of osimertinib runs into the hundreds of thousands of dollars, which is not which is beyond the reach of a lot of people, but I think is something we as a community need to work on as well. So I think my short answer is that we don't have a lot of evidence to guide us at this moment, but I think there is a potential rationale. So I think it's worth a discussion.
Can I just jump in there too real quick? Just in seeing the questions in the chat, I think you brought up a great point about the financial toxicity, because if you're not on the trial, typically your insurance isn't approving alectinib. Just correct me if I'm wrong. I just want to make sure we're clear, right? Isn't typically approving the TKI before stage 4, because people are saying like, what, can I take it longer than 2 years? Or so it's, can you just weigh in on that a little bit? Like, even if you want to give it to your patient, after chemo.
Sure. I think I can sort of probably speak more from the sort of Australian perspective, but I think this is sort of a pretty global perspective that the approval is for advanced disease, not for early stage disease. The approval doesn't have a time limit on it because the trials in the advanced setting didn't have time limits. In the early stage setting, I'm sure discussions already well advanced with the FDA about approvals, but the approval will be in line with the clinical trial, which is 2 years of treatment. And that's, I think I can see questions coming up about the duration of treatment. That's another absolutely open question as well.
But the trial data is on a 2-year basis. Is that correct, Dr. Solomon?
That's right. Yeah. So in the Alina trial, there was 2 years of treatment with alectinib. The ADAURA trial, which is the trial with osimertinib, had 3 years of treatment. And I think there's a question why 2 years, and that's a good question. And I think it came down to when the trial was designed, we didn't have the data from the ADAURA study, which was 3 years of osimertinib. And the sense was that longer would be better, but it's also longer also means that there's more toxicity in terms of side effects, financial toxicity as well. So it was a trade-off between sort of duration of therapy and sort of balancing that with toxicity. And it was somewhat empirical, but 2 years what was chosen. There are some studies looking at longer durations of therapy in EGFR lung cancer with osimertinib, and there will be some other studies with longer duration of therapy with alectinib that are coming. But I suspect that I think the approval, which will be based on trial data, is likely to be for 2 years.
That's good to see. I see one of the questions here also relates to quality of life, and I had similar question as well, thinking TKIs do tend to offer a better quality of life than chemo, but some patients do have difficulty managing the side effects. So can they dose reduce? Will this have the same efficacy? Is any of that known at this stage?
Yeah, that's another good question, and yes, we absolutely shouldn't sort of dismiss toxicity. And I do get the sense that it's a little bit different from the advanced setting, because in the advanced setting, often before starting treatment, patients will have some symptoms of their lung cancer, and when they start treatment with the TKI, those symptoms will improve, which improves quality of life. Whereas in the adjuvant setting, these patients have just had surgery and they have no symptoms related to their cancer. But I think, as you've seen, the side effects really are very similar in the early stage setting. And about a quarter of patients needed to have their dose reduced because of side effects, and that can be, as I'm sure many of you know, can be a very effective way in managing side effects. We haven't yet done an analysis of outcomes in patients who had dose reduction compared to patients who haven't, but that would be an interesting analysis. My hunch is that it won't affect outcomes, but we'll need to sort of formally do that to be confident that that's the case.
Okay, thank you. I see another question here was just asking, is this data for alectinib alone? Are there other TKIs?
Yeah, so the data are for alectinib. Do we know that it applies to other TKIs? One would think it likely, but we don't know that for sure. I guess in the situation that someone had a toxicity from alectinib that meant that they weren't able to continue with the alectinib, could there be a discussion about swapping to another newer generation TKI? I think that would be a reasonable discussion. Absolutely.
Yeah, that's good. Someone else, just an interesting remark, someone else said they're stage 2B, I believe I flashed past, and they've been on this for 3 years. So it's interesting that some people seem to be following the protocol, but maybe not part of the trial exactly the same way.
Yeah, and I think it is a tough one. So I remember when we were doing the trial, and when we got to 2 years, I asked my patients who were on the alectinib, if the duration of the treatment was for 3 years, would you be happy to continue? And all of them said they would be happy to continue, but all of them were also happy to stop because of they were happy to get rid of the mild side effects that they had. So I think it is the optimal duration of therapy is a really open question, and I think in the future we'll have to have better ways of identifying risk in patients. And there are some patients who might have tumors or a blood test which shows a very high risk profile, and those patients might need a longer duration of therapy, whereas other patients might need a very short duration of therapy or not even need adjuvant treatment after surgery. I think that's probably the future of having a really personalized duration or personalized adjuvant package for individual patients, but where we're sort of not there yet, and a clinical trial is a pretty blunt instrument.
No, that sounds really exciting, especially around maybe minimal residual disease and using blood biopsies to kind of measure what's going on. So that would be truly personalized. Sorry, Summer, I think you were going to jump in there.
That is a great point. Somebody just asked too about the conclusive data for overall survival. I think it's great that you haven't really been able to determine that, right? That's a good thing. But
yeah. So that will take time to come. I would argue that in terms of reducing recurrence, controlling disease in the brain, we've probably got enough to make it a valuable treatment. And I think we've learned a lot from the ADAURA study with EGFR. And if we know in the ADAURA study that at 5 years, there were 10% of people who were alive because they were on osimertinib compared to patients who weren't on osimertinib. And if the drug, and fortunately, the drug was approved, at least in the US, on the basis of disease-free survival. If we had waited for that overall survival result, those 10% of people wouldn't have been alive. So I think it's a compelling reason to sort of use disease-free survival as an endpoint, especially when the magnitude of the effect is as big as we've seen.
Someone here was asking if you know of any studies that are looking at staying on alectinib longer than 3 years after a lobectomy for stage 3. I guess.
Yeah.
Question.
No, it's a really good question, and there is a study that Roche are planning to open, and it looks at a longer duration of treatment, and it also looks at trying to combine chemotherapy with the alectinib as well. So a sort of different way to sort of intensify the treatment.
That's great. I guess one question that we were also thinking about earlier is, if you have been on this trial and you come off the TKI, you do relapse, is there a view for what TKI you should go on next? Should you go back to alectinib, or do you test, and what's the move?
Yeah, so I think it probably depends on when recurrence happens. If in the situation that you described, that someone had finished the alectinib treatment and maybe a year later develops a recurrence, I think there's a good chance that they would still benefit from even going back on the alectinib. In the situation that a recurrence develops during treatment with alectinib, then I think we're learning that something's happened within the wiring of the tumor that's made it made alectinib ineffective, or not be effective anymore. And I think in that situation, it's imperative to get a biopsy to try to understand what's going on, and then use that to help select treatment. And potentially also in the recurrence, even after you stop alectinib, a biopsy could be helpful in understanding what's happened in terms of mutations within the tumor. But I think particularly in recurrence on treatment, really understanding why that's happened is critical.
Someone had a really interesting question here as well, saying, Doctor, whether or not you think a trial for stage 4 ALK and chemo and alectinib, rather chemo and alectinib for ALK-positive would be beneficial.
Yeah, so that's yeah, no, we have thought about it. So giving chemotherapy plus alectinib for newly diagnosed advanced a patient with advanced disease is the question. Yeah,
That's right.
So yeah, I think there is something attractive to this idea conceptually. It's the sort of the hit hard, hit early approach. So, to really try to sort of reduce the number of tumor cell clones, to hopefully delay, really knock down the number of clones that survive within a tumor, to hopefully sort of delay when the tumor can becomes recurrent, or hopefully even improve survival. A similar study was done in patients with EGFR lung cancer called FLAURA2, where patients had chemotherapy plus osimertinib, and there's improvement in progression-free survival, but that came at the cost of a fair bit of additional toxicity. And I think we're really waiting to see what effect it had on survival before switching to that. So I think the same would apply for ALK lung cancer. But again, I think this is a situation where if we were really able to, at the time of diagnosis, be able to sort of look into the crystal ball and say, this is a tumor that might not do that well with just single agent TKI, those might be the patients that we direct towards intensification with chemotherapy plus TKI. So I think it's a valid approach. Our challenge will be working out who needs to have that, because it will add toxicity, but potentially efficacy.
That's a fair point. Someone was also asking about a case where someone had a lobectomy that just seemed to removed all their cancer. So I'm not sure what stage that would make them, if it's 1A before 1B, but would they be appropriate for a trial like this as well?
And does it matter how much this other question is coming in too? Does it matter how much time has passed? Like you said, it was 12 weeks. Now, if it's a year later, can they still participate, or, start?
Yeah. So firstly, with regards to size, so in the trial, tumors had to be at least 4, if there were no involved lymph nodes, a tumor had to be at least 4 centimeters in size to qualify for the trial. We don't know. We don't know for tumors smaller than that, but I think there's always these lines are always somewhat arbitrary, and if a patient had a tumor that was 3.9 centimeters, I think, and the patient understood what was involved with 2 years of alectinib, I think that wouldn't be a crazy thing to discuss. In terms of, sorry, Summer, I'm just forgetting what you were asking.
Does it matter? Sorry, just originally, I think with the trial.
Yeah, the time, yeah. Yeah. So yeah, that's another really good question. For a long time, when the trials with chemotherapy after surgery, there does seem to be an effective time if and we sort of recommend starting chemotherapy after surgery within sort of 8 to 12 weeks. And the longer after the surgery, the less potential benefit. And we've also seen that with immunotherapy after chemoradiation. Patients who start within 6 weeks have more benefit than patients who start more than 6 weeks. So intuitively, I'd say the earlier the better. Is there an absolute cutoff when there wouldn't be benefit? I'm not sure, but I think we can only speak to sort of what we've sort of learned from the trials. So in the trials, 12 weeks was sort of the outer limit. I would think that there would still be some benefit a bit longer, but I'm not sure after 6 months or 12 months whether there would still be the same degree of benefit. We just don't have evidence to guide us to answer that question.
Thank you. And we have a few more minutes, right? And so Yvonne, I want you to be able to finish up with the question. And I also see one here too. And remember, everybody, hang tight and stay on so we can thank Dr. Solomon, and then I need your help. Okay. But somebody said just for stage 4 patients, which we have a lot here, again, they wouldn't stay on for 2 or 3 years on alectinib. We want to ride it out. Can you speak about that? We're not coming off of the TKI and why?
Yeah, so I think in the stage 4 setting, so I guess the stage 4 setting and the early stage setting are really quite different settings. In the early stage setting, there are some patients who may be cured even without the TKI. The surgery might have been all they needed, and the TKI really doesn't add anything. And in those patients, continuing indefinitely is really only adding toxicity without benefit. Then there's some patients that when we add the TKI, that really changes outcomes for them, and those are the ones that we want on the TKI. And I think duration of treatment is uncertain. But in the advanced setting, what we've learned from all the TKIs is that there's probably only one exception that I'm aware of, that it is important to keep the pressure on the tumor with control or continued TKI. The one exception that we have is CML, which is a hematological malignancy, which can be driven by another fusion, a fusion in a gene called BCR-ABL. And in some of those patients, we can get to a situation where we go into a molecular complete response. And some of those patients, we can stop the TKI and they can be cured. I know Yvonne's going to ask this, about where we're going, but I would like us to get to the stage that we can do that in patients with advanced ALK-positive lung cancer, that we can really sort of hit the tumor hard enough to get down into not just a radiological complete response, not just a circulating tumor DNA complete response, but a really, really deep, we probably don't even have the tools to sort of measure how deep that would need to be at the moment, response. And that's sort of, that's where we want to get to, because that's if we're going to head towards cure for advanced disease, that's where we need to move. And I think we can learn from the early stage setting how to do this. So we're going to have tumors that are in the lab that we can look at from these surgeries. I think there's a lot of interest in looking at what are called persister cells and how we can deal with them. They're a barrier to cure in the early stage setting, but potentially also in the advanced setting as well.
Wow. Dr. Solomon, we could listen to you all day, and really already just hearing what you were just saying there, the idea that we could cure stage 4 lung cancer, get that kind of effect is just so exciting and gives us so much hope. So maybe just the last question, because I want to get you to clinic on time, is there anything really exciting that's happening out there in the market at the moment that you think this is something really we should all be watching, we should all be thinking about for the future as well?
Yeah, I mean, I think probably there's, I guess what's sort of new is the early stage setting. I think the neoadjuvant setting is really interesting because I think we can learn what we learn from that when we actually operate on tumors after patients have had alectinib or lorlatinib, for example. We can really see what's happening to those tumors. You know, we can sort of potentially learn about the biology of the persister cells that we talked about, and that might apply to the later stage setting as well. In the so I think that's exciting, neoadjuvant therapy and what we can learn from it. In the advanced setting, I think we're, hopefully this year going to get the 5-year results from the lorlatinib clinical trial. I think those will be really, important. I saw the sort of, the question that Summer asked about how long people have been on treatment, and I think showing that these drugs can have really long-term effects is important. And I can't share the results with you yet, but hopefully we'll have those results at ASCO to share. And then I think there's some newer generation ALK inhibitors, including a compound from Nuvalent, which are in clinical trials, which are also interesting.
That's great. So listen, we won't keep you any longer. I think we'll just let everyone here say a big thanks to taking the time out this morning to speak with us. And we look forward to hopefully welcoming you back again. Thank you.
Absolute pleasure. Thanks so much.